everybody's got a seat and can hear us okay. My name's Nicola, and I'm the chief nurse at the Royal College of Nursing. Been there nearly a year on the 7th of December, but previously chief nurse in acute trusts for 10 years. And it is my absolute privilege to be here on the panel with our chief nurses. Sadly, Maria from Northern Ireland can't be here, but I'm going to get each of the panel to introduce themselves, and I shall start with you.
Hi, I'm absolutely delighted to be here. I'm Anne Armstrong, and I'm the Deputy Chief Nursing Officer at the Scottish Government in Scotland. I've been there around 2 years, but before that I've had a very varied career, both mental health nursing and general adult nursing, executive director, non-executive director, variety of roles. So it's an absolute privilege to be working in the job that I'm doing just now and to be here this afternoon.
Thanks, Anne. Sue.
Nanda, Akroiso. That means good afternoon and welcome to everyone. My name is Sue Tranker. I am the Chief Nursing Officer for Wales and Nurse Director for the NHS in Wales, and absolutely delighted to be here with you this afternoon.
Thanks, Sue. And Ruth.
Hello, my name is Ruth and I'm the Chief Nursing Officer for England, and I'm delighted to be here today. Good to see you all and to be here.
Thank you, Ruth. I've got to say, I feel like I'm on a version of Heidi Hyde. Do you remember that TV program years ago with the ding dong and the bing bong? It feels a bit like that at the moment, so a bit disconcerting. Ruth, I am going to start with you. I think when people see senior people like yourselves, they sometimes don't think about your career, and I would really like to ask why you became a nurse and why you would encourage someone to be a nurse today.
Why did I become a nurse? Well, I could give you an official answer, or I could give you the honest answer, the me answer. I grew up in Wales, not far actually from where Sue is living now. I had a very, very humble beginning. And in these days I would have been on a food bank. My mum was a single mum with my sister, and part of the reason I became a nurse is because I had to earn. There was no money in our household, so I had to earn, and I wanted to go to university to become a chef and study home economics, because that's what I did an A-level in, but actually I had to earn. And the profession I wanted to do in order to earn money was actually nursing, so I'm here.
Yeah.
And why would I encourage people to become nurses? Well, it's the opportunity to be there at someone's most profound moments of their lives, whether that's good, whether that's the birth of a child, the loss of a child, the loss of somebody, or the success of somebody's operation, or just being able to be there, technically providing brilliant care, using our safety critical experiences and knowledge, and being kind.
Thanks, Ruth. Sue.
Why did I become a nurse? So some of you will have heard this story before, and like Ruth, we all have a personal thing, I think, that impacts us. For me, 29 years ago, I had a little boy. I think I've said this story before, so forgive me if I make anyone cry or if I cry. So it's a really painful story, but it's a really positive ending. So I had a little boy, he was 2, he became incredibly unwell all of a sudden, and he spent a year in an intensive care unit, being cared for by the most brilliant of nurses in a developed country and a developing country. So really quite a struggle. After a year of spending his time in intensive care, they asked me to take him home, and they said, palliate your son, he's not going to make it. And I was a young mum with a family, of course, and my mum and dad and then husband. We took him home and we looked after him for a year. And during that time, the community children's nurses, as we know them now, they wouldn't have been called that then, they would have been called your community nurses, right, or your district nurses. They were fabulous. They came home, they looked after him, they palliated him, they cared for him, they fed him, they changed him, they did his physio. They were absolutely incredible. They took the stress of me as a young mum, trying to be a student nurse at the same time and study. They just showed me what humanity means. They showed me the difference you can make. And he was really, really sick for that time, and we nearly lost him. He's actually 29 years old today. He's a big strapping lad, as Ruth knows. He was 30 actually. He's a big strapping lad, and he's got some deficit, of course, because you don't go through that sort of thing in your life without it. But I can tell you hand on heart, he would not have been here today if not for those community nurses. And I would not have been here today if not for those community nurses, because what they did for my son was not just look after him, they looked after me. And I know, because I was many times at the point where I thought, I will fall off the edge here. I am going to, and if I'm not going to fall off, I'm going to take myself off the edge. And actually they held me, they kept me, and they kept us safe as a family. So that's what brought me into it. I was only in my first year of nursing when this happened. And I thought, because I really wanted to be a doctor, by the way, so I wanted to go to do medicine, and I grew up in segregation and apartheid, structural apartheid, which didn't allow me necessarily to go and do that, what I wanted to. So I had to go via nursing, and I thought I'd step off in nursing and become a doctor, because that would be my route. And actually after that experience, I thought there's no way I'm going to do that. And I have loved being a nurse for every single year since then.
So I think that was completely inspiring, actually. And for anyone that heard Crystal earlier, there's something really powerful about saying you're not just a nurse. Nurses have the most unique contribution that is equal to our medical colleagues, actually. So thank you for that. Anne?
Well, when I started out 17 and a half, I wasn't actually very sure what I wanted to do, if I'm absolutely honest. You know, like you leave school, you've got your qualifications, and you're thinking about the way ahead. And it was my dad who recognised that I should have a caring disposition and was thoughtful, and I should start nursing. And he said, humour me, I think you'll love it. And to be honest, I have never looked back. I absolutely found my forte. I started in mental health nursing, and I was absolutely amazed by the people that I met there. Many who had been in hospital for a very long time had become very institutionalised. Sometimes actually they were in because they'd been pregnant out with marriage. You think of those old Victorian ideas. And then to see them transform and really shift and live out into the community, whether that be in their own accommodation or in cluster accommodation, and survive and thrive, and see those big institutions just close down and folk go on with their life, leading their best life, and not in the walls of an institution. And to be honest, I found that amazing and humbling just to be part and parcel of that. It was hard, and watching my nursing colleagues actually address some of that stigma that people can't live here and they can't live over there either beside me, all that NIMBYism, but walking alongside individuals, keeping them going, keeping them focused, and they absolutely got there. And those institutions are long gone, and rightly so. And I think that's what I found really inspirational and made me want to go on. I found my forte.
Thanks, Anne. I have to say, I think in my lifetime, the change in mental health is unrecognisable. I also trained in those institutions, some of which things that were horror stories, actually. So fast forward from being when you started and now chief nurses and deputy CNOs, big jobs, massive responsibility, more than people sometimes realise. What do you love about the job? And I'm going to start with you, Sue.
What do I love about the job? So I'm going to say the right things here, because you might know I'm a civil servant. I'm a senior civil servant to the Welsh Government. So, so I'm just going to say the right things. So I would say what's not to love about this job. So being the head of a profession is an absolute honour. But with this honour, for me, comes such a huge set of responsibilities. The responsibility to do right by you, the responsibility to do right by this profession, for me to safeguard this profession when I move on when I retire, when I leave it in the hands of our future generations. So that's what drives me every single day. Every battle I enter into, every argument I have, every time I sit at the political table and push your agenda, every time I fall out with my minister, and every time I have to go back and apologize to my first minister, that's okay, because that's the thing that makes the difference for us as a profession. I'm not holding a seat, nor is any of my colleagues, but I'm not holding a seat because I want to sit here and be the head of this profession. I'm here because I want to make a difference. And I use my voice, and I use you, and there's my lovely team sitting in the audience who will challenge me and absolutely champion the things they want. They know they can do that. So I love that. I love hearing the voices to tell me what I need to do. And if I don't get it right, I'm absolutely open. You phone me up and you tell me, you've got that wrong. That's not how we want to do this. Ruth is laughing because she knows. I will take it, and I take the challenge, and I will absolutely listen, and we will work together to make it different. I'm not suggesting it's easy. This is one of the most difficult jobs I think I have ever done in my 32 years nearly of nursing, but it is the best job. And whilst I enjoy it, I will tell you I scream into my handbag every now and then. Those of you that know me, I have a certain handbag, I scream inside it. That's okay, it's a bit soundproof. But that's just to it's to get the pressure off. Or I phone up a friend. And that's the thing that makes this job even better on a daily basis, is that I can phone my friends and go, I really don't want to tell them to get off the wheel. And they go, no, buckle in, we're in this together. So, yeah.
Thank you. Anne, what about for you?
Similar to Sue, it's about making a difference. It is an absolute privilege, I have to say, to be working and being the voice of nursing within Scottish Government. What I really enjoy is going out and seeing and speaking to my colleagues, really getting a feel for what it's like every single day, and then being able to bring that back and then think through, what does that mean in policy? How might we make that different? How do we set those conditions that actually you enjoy going to your work, you're doing your best work, and we're getting the best outcomes for people? I also really enjoy speaking to people who are on the receiving end of our care and really getting a feel of what that feels like and how it could be better. And sometimes, despite us trying to do our best work, it can feel quite disjointed to them. They're not too sure what it is we're telling them. And then it's chatting back with my colleagues in the front line and senior positions across all of the organisations in Scotland about how do we fix this? What's the one or two first steps that we might take together to get some ownership and make a difference? But that talking to ministers in the right ears at the right time, providing the evidence, and then looking at the impact and seeing people thrive, it's a fantastic opportunity. Not easy, but it's really wonderful to be doing.
Thanks, Anne. Ruth?
What do I love about my job? Well, I've had a great morning this morning. I've just, first thing this morning, I was at the Women's Health here, the Women's Health Hub here in Liverpool, seeing nurses, care coordinators, and a teeny weeny bit of a GP, providing some amazing pathway work for women in Liverpool. The reason I say that is because actually the best bits about this job is being grounded. We all do it. We all go and get our mojo from visiting sites, talking to nurses, and getting honest feedback. And I'm looking here at Felicia. Felicia's always given me honest feedback. Felicia is our chair of the CNO Strategic Advisory Group in England. And actually, that's what makes me really proud too. And it gives me real joy when we're able to take some of that feedback, some of that listening, some of that seeing great care, and where it's not working, into the ministerial discussions. And we're able to say, actually, that won't work, because yesterday I was working on a clinical shift, or yesterday I was here, and that means it will work. So when we come out collectively and visit, it's visiting to understand, so we're able to take back and influence. And that's the best bit of the job, for definite.
Thanks, Ruth. I'm going to follow on with that in asking each of you, we've heard what's great. I would like you, as honest as you can be, seeing as there might be a journalist in the room, what's been your biggest frustration since you've been CNO, Ruth?
I knew you were going to come to me first. I had my head down then. She still came to me first. Oh, two bits. I've had the privilege to lead the profession through a global health emergency, and my God, that is the toughest thing I've ever done. I guess there's two bits that frustrated me. One, which is we haven't yet really combated racism. We have not yet done that. There's been a lot of great work by a lot of great people. The CNO SAG have been going now 22 years. The Jabali Network is a men's network of black, Asian minority nurses, male nurses in England. Been going now 2 years. They've done some amazing work. But Michelle Cox here, a heroine in nursing, is testing me where we get it wrong. So that's a big frustration. And I guess so on a personal basis as well, the lack of integrity by some people is a massive frustration to me. And you probably know what that's about.
Thanks, Ruth. Thanks very much for your honesty with that, with Ruth. Thank you. Sue.
I don't think I'd say anything differently to what Ruth has said. I think inequalities is it's a big agenda, but I think it's my biggest frustration. I often wonder when I'm not in the room who will hold it up, who will keep the flag flying. And it has to be said, if we're not in the room, we do have great allies, but the flag isn't always kept flying high enough. And I think, how will we break that mold? We've got to do that for inequalities. There's a really nice saying, isn't there, that the way you treat your most vulnerable and your most unequal in society is a sign of a really civilized society. And I think I often come back and circle back to that in terms of us as a civilized society and what is it we're trying to achieve. You only have to look in the media these days to understand the division that's being created that is really, really tough. And you can't underestimate that for people like me that sit as a head of a profession and watch and observe my fellow colleagues who are struggling and really struggling. And so I think that's really tough. The second thing I think that I find most frustrating is just when I look across the devolved nations, I'm in a devolved healthcare, and that means we make our own legislation, we have our own laws, our own regulation for health. And I think the inequality from a devolved perspective is somewhat really unacceptable within a United Kingdom context. And perhaps I shouldn't say this because I'm not a politician, as you know, but I'm going to say it anyway. And I think what I then see is the levels of deprivation and inequalities that persist, and we cannot break through from that devolved perspective. And I think that's the bit that is the most frustrating. And I didn't appreciate that fully until I went over the border, because I really thought we were all equal. But when I got there, I realized some of us are just more equal than others.
Thanks, Sue. It's really interesting that you say that. It wasn't till I came to this post that I realized how England-centric I was, actually. And all your points about equality, so vital to change and get better. Anne.
Yeah. For me, I'm quite an impatient person, so I always want to go faster because I think there's lots and lots to get done. And I know there's due diligence and governance and assurance and making sure we get things right, but I always want to go faster. And I was like that in whatever job I was in, I want to go faster. And the other frustration for me is go faster, but go more joined up. So there's lots of policy being developed across organisations, across governments, but quite often they're maybe not joined up to each other. So you can have one policy that might abut against another that we haven't perhaps thought through. And it's also that so what, in developing this, what is it we want to actually achieve? And how will we know we've done it? And how do we make sure we do even more of it? So some of that is my frustration. Please go faster, and can we join up more and more and more around that person?
Thanks, Anne. So in your roles, you have huge access to politicians. We have an election coming up. What would be your advice to any government coming into power for nursing? You both decide who goes first.
You go. You go.
I'll answer because I don't think you can answer, can you? Sue and I are in a slightly different role in that Sue's in as a senior civil servant, I'm not. So it means I have a little more ability to say what I really want. So what advice would I have? I was very fortunate to be around as CNO the last time there was a manifesto commitment and last time there was a general election. And I remember working with the current government, actually, that is not the same Secretary of State or Prime Minister, because I've seen quite a few of them off. But I shouldn't have said that last bit. I shouldn't have said that last bit. What was I going to say? Oh, yes. I had the great opportunity to influence the manifesto commitments. And, you know, I had 5 or 6 things I wanted, and we got 2 of them. You know, we had the £5,000 maintenance grants started up again, which was good. It's not free education, but it is the start. It was much better, and we did see increase of student nurses as a result. And we had the 50,000 ambition for more nurses. And that wouldn't have happened if we weren't influencing the next government or a future government. And, you know, we'll be doing the same again. And that is what I'm doing right now, the same as these guys are doing, but they can't say they are because they're civil servants. We are doing that just now, influencing what the politicians are putting in their manifesto commitments, advising them. So what would I say to a new government? I wouldn't say anything to them. I'd say, go and experience being a nurse. Go and be a district nurse for a day. Go and see what being a care home nurse is. Go and see what it is to be an inclusion nurse. And then go and see what it is to be a hospital nurse. That's what I would say to them.
Thank you. I'm not going to push either of you any further, so I know that you're not. Of course you can.
So I don't want to respond to that question simply because I can't. But what I do want to say to the nursing profession and those of you that are in the room, I would say when it comes to the next general election, please, please use your voices freely, but use your choices wisely. That's all I'm going to say.
Absolutely right. And any of you that were here first thing this morning when I talked about some of the key challenges, I think we laid them out very, very clearly. And however hard you've all worked and have that voice, we do know that nursing in whatever setting, whether it's a GP practice, community nurse, paediatric nurse, acute hospital nurse, social care nurse, it's not easy at the moment. And, you know, I talked this morning about the fact that the RCN led strike action for the first time in its 100-year history. And what we heard from the nurses on the picket line, it was about their pay, it was about their conditions, but it was about safe staffing. Safe staffing matters to our profession more than anything else, actually, I believe, because you can't give outstanding care without the right number of people with the right skills. So what do you think we need to do to really solve this problem of safe staffing in all settings? Anne, I'll start with you.
Well, in Scotland, we have the Health and Care Staffing Act, which will be in legislation, it is in legislation, and will go live from the 1st of April. And that will include reporting on performance around safe staffing, and it will be heard in Parliament, using a number of tools. And there's clear guidance around what that means and entails, and we're testing all of that just now, and we are on track to go live on the 1st of April. But it is only part of the answer, because we need to grow the workforce as well. And as part of the pay negotiations with the RCN, we did agree to have a task force group chaired by the Cabinet Secretary for Health across nursing and midwifery, and it's looking at a wide range of issues. So attraction, recruitment and retention, well-being of the workforce, and looking at how do we create those conditions to grow that workforce and to retain them for as long as we possibly can. We're actually listening to what people have to say, what it's like to work in the front line, what would make a difference to folk, so that we can then pull that in and develop our approach going forward. So we hope that will report middle of next year, hopefully, and we'll have a plan around that. So that's the work that we're going to do. Of course, we're doing things like earn and learn, testing that out. We've got great impact in that in some of our areas, particularly in mental health, but there'll be a range of approaches that we'll take as we go forward.
Thanks, Anne. Sue.
Thank you. So in Wales, you'll know that we've been the first country in the United Kingdom, and in fact in Europe, to have legislated for nurse staffing levels. So we have the Nurse Staffing Levels Act Wales 2016, and much work has been done since to develop a systematic, triangulated methodology to work out the numbers of staff you need. And whilst that's great, and I'm really proud of having a legislation that underpins the way in which we staff our wards and our acute areas, it is only for acute medical and surgical areas currently. I think it naive of us to consider that legislation in and of itself is the answer. And I think we mustn't go down that route. I think it is one of the things and one of the pillars that continue to support, but when the conditions are not right for the workforce, if you don't have the right people coming into the workforce, if you don't have the right supply routes into the workforce, if you don't have enough models and routes into nursing, if you don't have the right conditions of looking after the people that are working for us, well, you can forget the legislation. That doesn't do anything. And I'm finding that and seeing how that works in Wales currently. So whilst it's great to have it, you have to have it at a point when everything else is ready and can support you to thrive. Or when you introduce it, you then bring the other things along with it. Because on its own, it is really naive to think it will bring the rest of the conditions that are necessary to enable us to activate safe staffing levels. Having said all of that, I am absolutely clear that safe staffing levels is the way forward for both yourselves in preserving your own health, mental health, physical health, and how you work in the workplace, and also for the patient care we deliver. I am also really mindful of the multi-professional framework for nursing, for care delivery. I don't think any longer in this 21st century, and as we look to the future, it is simply and solely about the numbers of RNs versus the numbers of healthcare support workers. If we want to think about how we deliver care safely for the future, then we as a profession need to think about what is required by the patient who's journeying through our doors. What do they need? And then where do we come in? I come from a prudent perspective here, and I think you've all been highly trained. We've heard about being safety critical professions, degree trained for the last, 23 years or so? So when we train you to this high level and high standard, then you should only be doing what you're trained to do, right? So who helps the complementary skill set and the complementary work that comes around the RN? We're not diluting it, but who's helping to support that delivery of the RN skill set? And I don't know if we're in that space yet. When we think about staffing, that we think about it in its most comprehensive and wide-ranging set. I think, unfortunately, as a profession, we probably, Nicola, still a little bit in the RN versus healthcare support worker. And I think that's something I would like to see being discussed far wider and far deeper.
Yeah, I think Sue raises a challenging point. I think we know the research around registrants and the impact that they have on care, but for me, sometimes I always thought if I ruled the world, I used to work in America, and it is about healthcare support workers and RNs, but the difference, I know it sounds ridiculous, but when I was in America, having a ward clerk 24 hours a day and never ever having to answer the phone or open the door, you wouldn't believe the difference it makes to your life. So I think it is about what do we need to make our lives easier, but without as you say, diluting the role of the registrant. And I absolutely agree with Sue's point around it isn't just legislation alone. But, I believe that setting that maximum number of patients makes a difference. And what we can see is those countries that do that in both Australia and California, you make a difference to recruitment and retention. So a big issue that I know we're going to enjoy trying to solve as a team. Ruth.
Indeed we are, Nicola. Indeed we are. So absolutely I agree. One of the things I will take away, one of the many things I'll take away from this pandemic is teamwork, how we flattened hierarchies during the wave 1 and wave 2 in particular, how we all came together as teams. And you've described beautifully and very eloquently the role of teams, as well as the very important role a registered nurse or midwife plays in that team. So back in 2018, we published the National Quality Board guidance, the 10 things that we need to do. And the first thing, Nicola and I were talking about this earlier, or last night, one or the other, but we were talking about how the first thing was organisations or trusts in England had to publish their staffing models and their staffing figures in public. Now that was a big thing. It wasn't something that could be hidden. We had to take it to the board in public. And that actually drove a big number of vacancies, actually, because we didn't have the nurses to fill them. So as part of the Industrial Action Agreement, there was an offer. The RCN and other unions and colleges were part of that. And we now have an arrangement where we've got the Agenda for Change board. Mark Radford is leading that. Nicola, of course, is on it. As well as Patricia and colleagues, the RCN, the RCM, unions, and a lot of people are on that advising. But one of the things that we will need to make sure is that that's something that we all can sign up to. And that's going to be the work that we will do. Nicola said that it's the work that we'll do, and that's the work that we will do. It won't be an easy piece of work. There will be some debates, there will be some reviews of the academic evidence, and we'll look about what's worked in Wales, what hasn't, the same as internationally. That's our job, and we'll do it together.
Absolutely brilliant. And I know that this is what matters to nurses, actually, and I think it will be exciting. And we talk about people like Professor Linda Aiken. She says, you may not see the fruits of your labour for 5, 10, 15 years, but we do need action now. So I know the RCN and the CNOs are going to enjoy that very challenging journey. One of the other things that we know it isn't just about numbers, it is about the skill and the brilliance of looking after patients. And one of the things that was really apparent to me as a chief nurse when I was at King's was during COVID, a lot of our medical staff were redeployed to work alongside nurses. And I've got some colleagues here from King's, and they will know that our liver consultants are seen as the busiest and probably doing the most liver transplants in Europe, the most important sometimes. But actually, a couple of them fed back to me it was harder to do a 12-hour shift in a critical care unit than anything they possibly could imagine. Couldn't believe they could just wander off and get a coffee when they wanted. But what really struck me is that for medical staff, their CPD, their research, their teaching their juniors, their fixed clinical sessions is within their paid hours. What do we do? A colleague earlier brought up a brilliant point about mandatory training. That's not education. It's tick boxes, and it's usually quite boring, let's be honest. So what do we do as nurses to value ourselves and bring CPD as part of the way we work? I'll start off with Ruth.
So one of the things I remember doing very first, actually, with Dame Donna Kinnair, the previous RCN chief executive, was how we got £150 million into CPD in England, which was £1,000 per nurse for every 3 years. Now that is not enough. CPD is there for your professional development. I remember when I was a very frontline nurse, CPD was really important. It's important for safety, it's important for going on to do career development, it's important for patients that we have highly educated, skilled nurses, as well as then, of course, for retention. It's also important to reflect that CPD is one of the things that we need as part of our implementation of the pay award that we need to tackle together. And if I was to ask you to be talking to your MPs going into the next election, I'd be asking you to raise that CPD is important, because your voice into your MPs does make it work. When MPs' postbags are full from nurses about what they want, they listen. So I would ask you to fill their postbox, because it makes my life an awful lot easier when nurses are voicing and using their voices, because that's important.
Ruth, I think you're absolutely right, Sue.
So I won't ask you to fill anyone's post boxes because I'll get into trouble over that. But yes, no, you must use your voices. It's really important. So what would I say? I'd say, look, when the health sector is under pressure, what is the first thing that goes? Education, right? That's the first thing they cut. That's the first thing we're asked to look at. And I would absolutely say the reason that we go there is because it's seen as an easy win. And why is it seen as an easy win? Because do you know how much CPD allocation you get every year? Ruth mentioned a bit of money now. So yeah, I see people shaking that you don't. We don't know. We don't know. So the value of your CPD is lost on you, unfortunately. So I would ask you to consider, how much CPD allocation do you get every year? How well do you navigate your landscape to access that money? When I was a trust chief, they cut me off. That happens sometimes when I speak. It's the Welsh Government. I wouldn't be surprised. Wouldn't be the first time my mic was turned off when I was speaking, by the way, just so you know. So how well do you navigate it? When I was a chief nursing officer, I gave back CPD to the bottom line every year. So much of it. I'd send it out. I'd say training needs analysis. What do you need? What do you want? Here's the money. Go and make it happen. But it couldn't work. But it also doesn't work because we don't have the right staffing, right? So to release you is really, really tough. So we put you down for training, you accept it, then we can't release you, or you go for 1 or 2 sessions. So all of these things are intertwined for me. So when we start to talk about legislation for staffing, all of this needs to come under that, in thinking through what are the conditions that we need to get right in order for you to really thrive. And you needing to thrive, it's not so much the funding. Of course, Ruth needs much more than me, and everything she gets, I get a bit of it, as you know. So if you work for Ruth, I'll get all of the consequentials my side, so I'm always happy with that money. But it's not so much the money. It's the other conditions that can enable you to do that. And then CPD with a purpose. That's the other thing that I think is missing. When I ask often, how does your CPD requirement or request align to the CNO priorities, or align to the organizational priorities, or align to a healthier Wales in Wales? That's our strategy. I don't get the answer very clearly. It's a lot of making it work. You've got to make that argument cogently to help us to then find and try and release that funding for you. I'm committed to CPD. I think it's really important, and I know in the non-pay we've had that into ours as well, so we are working through that. But I think we've got some more work to do in really making the cogent argument around what is CPD, what it's used for, how it's used, and how you navigate it. So yeah, that's my bit.
So, Anne.
I agree with all of that. It's absolutely key. If you think about the services we're delivering and the huge demand, we need to change what we're doing. There's always new evidence, there's always new interventions that are coming up, whether it's digital or so on. So we need to absolutely ensure that we are doing our best work. And you can only do that if you're developing and keeping up with the times. Like Wales, we have included protected learning time as part of our pay settlement, and we're in the process of just working through. So what does that mean in reality? How many hours is that? And what will we do or use that CPD for? So actually it makes a difference, but in 2 ways. One, to how we care for people and the types of service we're trying to deliver, and that you're able to thrive and feel you're doing your best work. But the second part is also important, and it's about career aspiration and succession planning. Where do you see yourself going? What's your aspirations? And what might you do to get there? Working in different ways. It might get us a secondment to an area. How do we make that happen? So I think we need to focus on how we deliver from the board to the floor, great care, but also your aspirations and succession plan. So there's a queue of people waiting to be the next Chief Nursing Officer, the next DCNO, the next Exec Nurse Director on a board, and so on, right across the piece. There is loads of us. There should be huge queues of people waiting with those right skills and experience to step right into the next job.
Thank you. I think I am taken by what Crystal said earlier. What do nurses do? We save lives. If we were pilots flying a plane, CPD wouldn't be seen as an added extra. It would be seen as essential. So we do need to have voices. CPD has to be the way we look after our patients brilliantly. We haven't got much time left. I think we started this interview reminding ourselves that our CNOs are at the core of it, nurses. And I know the previous panel discussion said it isn't just nurses that shape our lives, it's the people we have the privilege to care for. So I would, in my last final question, just like you, each to reflect on a patient that you will always remember and never forget. I'll start with you, Ruth.
Is a patient very early in my career, Evelyn Stokes, on A2 West when I was a brand new first year student nurse. She bought me a present, but I never got to receive it from her because she had a cardiac arrest and died. But she was an amazing lady. She impacted on me because what she wanted from me was my compassionate care. And the present was a flan dish, and I still got it, and I still use it. And the last patient, I'd say, for me, the second patient would be the last patient I cared for properly, which was in wave 2 of the pandemic on Colchester intensive care unit. I worked there a lot undercover. They knew who I was, but I didn't make much of a thing of it. But most Sunday mornings I worked in Colchester ITU as a nurse in that 1-to-2 ratio, in that 1-to-3 ratio, and there was a paramedic there that I cared for each Sunday. And I will always remember that.
Thanks, Ruth. Anne, I'll come to you.
I would say there's 2 patients very early on in my career. I'd done my mental health nursing and went to do adult. And I found myself in a busy medical ward in Glasgow Royal Infirmary. And it was within a week of each other. And it was a gentleman who was at the end of life with a range of cardiac issues. And he was crying. And he was crying about not his condition, but about his family. And they were in a lot of debt. His wife had a spending habit and would spend all the cash. And he worried about what would happen when he was gone. On the same week, rather around the ward, it was a mixed ward, I was back shift. It was visiting time, and I seen this screen round the bed. And being the nosy person that I am, I popped my head round. And again, there was a lady. She was crying. Her 2 daughters had come up. She was in for a week. And she'd fallen out with them. And she'd fallen out with them because while she was in, her husband had got paid and he'd drunk all the money. And there was no money to run the house. And it actually really grounded me. I was young. And you don't think about those things and the implications of what's going on with that person. It's just not their cardiac problem or their cancer or their depression. Actually, it's their life and how the determinants of poor health work. And therefore, when you're saying to someone, you can't work for a week or 2 weeks, what does that mean to them in reality and to their life circumstances? Can they manage? Does that mean a food bank? Are they able to care? So those 2 people have stuck with me throughout. And I do find myself, when we're looking at policy or new practice, what does it mean if we're doing a diagnosis? What does it mean for that person in their life? Not in terms of their clinical outcomes, but their life.
Thank you. Completely agree with that. Sue, last word for you.
Thank you. So some of you may know I come from Southern Africa, so I worked in South Africa for a long time. And when I worked there, it's quite a difficult place to live in anyway. So, if you're not carjacked or hijacked or you're shot with, shot, and this is just the kind of life we lived there. So I was working in an ED one day, and I think I've told the story. So I was working in an ED. We had a call that came in. When you work in an ED in South Africa, it's slightly different. You man a bed as a sister, because you're called a sister when you finish training. You man a bed yourself with a registrar. So you both have a major's bed to yourself. So the call came in, said gunshot chest on the motorway somewhere, in a car park or something like that. Can't remember. We got in so you get in the suit, you get in your heli suit, you get in the helicopter, you fly out, you go and pick up your patient from the tarmac, wherever they are. You pick them up and you bring them back to your ED. So we did that. And obviously myself and the registrar, the paramedics, everyone in the heli, we brought the patient back. We were kind of trying to save her life, didn't realize who she was, none of that, got her into the room. And when you work in South Africa, so you're already, as a very young sister, you are able to do everything from central lines to everything, right? You're doing everything, right? It's a completely different skill set. So we got in, we were putting in central lines. We called somebody to come on and help us because she had a gunshot chest. We needed an open heart cardiac massage. So we had everybody around us, and I didn't look at this person at all. It was just on the go, on the go, on the go. And at some point, someone said, does anyone know who this person is? We're like, no, we don't. And the doctor, the anaesthetist said, Sue, come over here and hold this tube for me. And I was like, oh, for God's sake, I've got to get this other thing done. And I came over, held the tube, and picked it up, and it was Michelle. Her name is Michelle. I went to school with her. And I stopped dead cold. I couldn't move. And I was like, oh my God, this is like, we schooled together. And so transpired. Her boyfriend, partner had shot her in the car park, and shot her at point blank, domestic. And you stand there and you think for a moment, I know the person, park your emotions. You can't cry. You can't get sad. You got to save her. You've got to get going. And I know her family. And I just remember, and we did save her. And she did go. She went into the cardiothoracic ICU and took many, many, many months of rehabilitation. And she got better, and she went home. And someone had told her that I'd looked after her in the ED, and I got to meet her again in her home. But she reminded me of how, I suppose, how short time is and how you never know what's going to happen. And shortly after that, I made a decision to leave South Africa. And that, for me, I'd say was the pivotal moment for me, when I stood there looking at my friend thinking, I can't do this anymore. I can't live here, and I can't come to work not knowing if I'll ever get home and see my family, because it's not just domestics that end up in that sort of, it happens all the time. You can be driving home and you'll be shot at. It was that kind of thing. And I just thought, I'm not doing it. So that's what moved me. But Michelle is now wonderful and thriving and married to a lovely man and very happy. But I think that was the moment for me that I'll never forget what we did as a group and as a team to save her life, but also reminded me of who's under the what's the cover? I forgot what it's called now. But I often think, who's under the cover? And because I hadn't paid attention, and until I looked, I realized it was my friend.
Thank you. I do want to thank our CNOs for being very open, candid, and more than anything, remind us why they do the jobs they do, and at the core of it, that they're nurses. We know we've got a massively challenging time. I spoke this morning about the RCN wanting to be the voice for nursing, but actually we won't do it alone. And I'm delighted that our CNO colleagues will be working with us every step of the way. So thank you very much for your time.